Absolutely.
Great. Right, well, hello everybody. Thank you very much for joining the webinar today. My name's Jo Bullingham. I'm the Charity Secretary for PoTS UK. We're absolutely delighted to see that so many of you have joined us. This will go on to our YouTube channel afterwards. It's being recorded. So it will go on afterwards should you want to revisit it or share it with anybody. So the link will be put up onto our Facebook page within about 48 hours afterwards. I'd like to welcome Dr Fortunato. Say a big thank you to him for giving up his time very kindly to come and speak to us today. I'm sure lots of you will have read the information, but just very briefly, Dr. Fortunato is a professor of paediatrics at Northwestern University in Chicago. He's a practicing paediatric gastroenterologist, and he's got some information to share with you today on PoTS and autonomic disorders, thinking outside the GI box. Just to give you a brief overview of how the session will run, it's going to take about 40 minutes for the presentation, and then we're allowing about 20 minutes afterwards for questions. If you will pop any questions you have, if you pop them in the chat box throughout, and then we'll try and cover as many as we can at the end. Very kindly, Dr. Fortunato has just said that if we're unable to get through them all, we will try and look at them afterwards and then communicate the answers after the event. So if we don't get to your question, we will do our best to revisit it after the event. At the end of the webinar, a link will come up to a very, very short survey. I think there's only about 7 questions, and it should only take about 2 minutes, but I would be extremely grateful if you are able to fill this in. It really helps us to shape our future webinars and to know what it is that you're looking for and what it is that you're finding helpful. So if you are able to do this, that would be absolutely great. I think that's enough from me. I'm sure this is going to be a really fascinating talk. So I'll hand over now to Dr. Fortunato. Thank you.
Introduction. And I appreciate the invitation as well. I will confess I'm still getting used to the idea of giving talks on Zoom and looking at my computer screen in my office. So my goal is not to make any crazy facial expressions, but I'm looking at a screen versus your faces, and I know that's a little bit of a challenge as we adjust to sort of the way the world has been, but I appreciate your patience with that, and I will do my best not to do any technical snafus. And as I'm saying, so I do pediatric gastroenterology. I kind of a bit of a long and somewhat interesting or checkered past, if you would. I actually trained as a general surgeon and with a focus in vascular surgery, which is sort of, I've had some interest in the vascular aspects of possible orthostatic tachycardia and autonomic issues. I'm also still, after 17 years, an active member of the US Air Force, and so with a focus in aerospace medicine. And I mention that only because, fun fact, astronauts, in fact, do get POTS coming back from space after prolonged periods of time. So it's sort of a different perspective in terms of seeing patients both from the GI standpoint and vascular and even in flying airplanes. And so I hope to maybe incorporate some of that into the discussion this evening. And last but not least, I have a watch next to me, so I will be mindful of the time. As much fun as it would be to talk for 3 or 4 hours, I'm sure there's a limit to how much you can handle of a gastroenterologist in Chicago. So I'll do my best to keep track of that. So just to start, I always like to just to give my disclosure. I don't have any conflicts of interest. Some of the work that I described was funded by the American Heart Association, and some of the technical work that we're doing towards patient interaction apps actually is being incorporated into a company which is currently in existence. And so I like to take maybe a different approach to POTS and GI tonight. And a lot of talks and a lot of discussion stems on what's the best test, what's the best treatment, which of course are important. But one of the things I've learned as a subspecialist in the field is perhaps taking a more holistic approach toward understanding the whole patient. And I think really toward that end, how do we approach patients who have multi-system challenges without getting so over-focused on one versus the other symptoms that are at play? And so finding the right test, really answering the right questions is really an area of interest of mine, particularly for patients who have autonomic symptoms, dizziness, and coexisting GI symptoms. I think more importantly is how do we integrate our specialists? I'm one specialist, but I work in close partnership with neurologists, cardiologists, pulmonologists, general practitioners, and really aiming toward how do we integrate that? How do we bring these silos together or break these silos? And my hope is that if it makes sense, if I'm doing my job right, hopefully some of the new technology and diagnostic tools that are becoming available may actually help not just patients, but the clinicians alike towards really working in a partnership and defining all the attributes to this complex condition. And so I thought I'm maybe more of a storyteller than I should be, but I thought I'd present sort of one of the typical patients that we've seen in our clinic. And I just want to give it from a different perspective in a moment. So I see a lot of young adults. Again, in PoTS, we see a fair number of female patients versus male patients, but we do see both. But this was just an example of a patient we saw who, and I highlighted some parts, a high-achieving individual who's coming to our clinic with chronic nausea and vomiting and dizziness. And interestingly, after an illness, presumptively flu-like or a viral illness, but she has symptoms of pain and constipation. She notes her heart's racing, some shortness of breath. Interesting, some change in color of her legs, which is not something that was asked prior to seeing the gastroenterologist. But again, it has downstream ramifications. She's lost weight, so she's becoming more malnourished. Of course, being a high achiever and a very successful young woman, she's anxious about missing classes, missing life, missing her honors classes. And when you look at her exam, I mean, from the GI standpoint, she has some distension in her belly, but otherwise the exam is not glaring at the start. And the one thing that we do, or my group does, is we are very aware of joint hypermobility issues. So we did what's called a Bite score to look for joint hypermobility. And so one of the questions I think is really, what is the problem here, and what are we seeing and what are we not seeing? And I think in talking to several of my GI colleagues around the country, oftentimes when the patient comes in, there's a whole bunch of gaps that are missing in the case presentation. So yes, it's a young woman with nausea, vomiting, pain, constipation. But those other dots or those other variables in the equation, the dizziness, the joint issues, sometimes that gets left out because it's not GI. And that is a challenge that we've experienced both in our referrals from general practitioners and pediatricians and internal medicine doctors, as well as even from fellow gastroenterologists. So it's difficult to say it's not in my wheelhouse when truly connecting the dots is so important towards the whole picture. That being said, unfortunately, when you're a hammer, everything tends to look like a nail. And oftentimes patients who presented with similar symptoms, we think of what blood tests are we going to draw. We think there must be something inflammatory. What x-rays do we need to do? CT scans and MRIs. Do we need to do endoscopy? As gastroenterologists, we love to do endoscopy, but unfortunately, the endoscopy is not always where the answer lies. And we've actually had some patients who, for chronic pains and symptoms, well, maybe it's a surgical issue. Maybe we need to take a look. And we've had a fair number of patients who've had their gallbladders removed, again, under reasonable circumstances, but not always a solution to the overarching problem. So I was born in New York City, so I have to at least reference the New Yorker. Sometimes if we look at the world as New York, New York, New York, and there's some other parts of the country, we lose sight of the big picture. And that's really what I hope to aim just in talking about our approach to patients with I get, for lack of a better description, autonomic dysregulation, of which POTS and orthostatic hypotension are a big part of. Now, the goal of this wasn't to discuss everyone around dinner time with these horrible pictures, but I keep asking, why does it matter? Because there is a consequence to everything we do, everything we don't do. And the one thing that we've seen in several patients is doing a test because we don't know what else to do doesn't always result in a solution. And unfortunately, tests are oftentimes invasive, even diagnostic tests. And oftentimes when it doesn't translate into a tangible solution or a treatment plan, there's more emergency room visits and hospital admissions, and it has a cost, it has a consequence, not just to patients, but to families, to your whole social circle. And not the least of which is that it costs money. And one question is, we spend a lot of money, but how can we direct that money towards really more focused solutions, again, towards understanding and improving the treatment. And I just mentioned a few studies here, not to overwhelm you with numbers, but again, when even simple endoscopic procedures are associated with complications, there's anesthesia involved. And what's challenging is we do these procedures, and by and large, for patients with functionally debilitating nausea or pain or constipation, oftentimes we don't see a whole lot during these studies. One of my colleagues looked at 25 to 50% of patients actually having some finding with endoscopy. More recently, when we looked at it for patients with pain, the vast minority of procedures actually demonstrated anything that was at all. In this case, it must 10% of patients with upper endoscopy having an abnormal finding, and 9.5% of colonoscopies. And so one of my sort of commitments when I talk to new patients is that before we decide on what avenue of testing to go, there really are two questions I ask my patients' families to ask me. One, if I'm going to subject someone to a test, what am I looking for? What's my question? And more importantly, when I get that information from the test, what's it going to do? How is it going to impact treatment? And those are two questions that every patient should be able to ask their clinician or care provider, and every patient should be able, or every care provider should be able to answer that, or either don't do the test or talk to another care provider. But again, like I said, all these tests do come at a cost, both in terms of family stress and trauma and financial cost as well. So what's interesting is, and I learned this from talking to a patient one time after a procedure. I always thought it was good news to come back from a procedure and say, your endoscopy is normal, looks good, nothing to see here. What I wasn't as aware of or mindful of at the time was that oftentimes translated into, I've had symptoms forever, you didn't find the cause, that's not what I want to hear. I want to hear what's wrong so it can be fixed. And it kind of got me thinking about, what are the questions people, or what are the statements that people don't want to hear. First, when you come to a specialist, to be told, oh, you don't have a GI problem, move on, go back to from whence you came, is not something that anyone wants to hear. Go back to your doctor, go back to another doctor. And quite honestly, it's not an insignificant number of patients who've been told, who come to me in the past, who explain, well, we can't find a problem, therefore it must be psychological, it's in your head. And that really completely just unvalidates or the significance of symptoms, and certainly serves no one any purpose, particularly our provider community and most importantly our patients. Symptoms associated with PoTS, as I'm sure everyone in the audience knows, regardless if they're easy or not easy to diagnose, they're extraordinarily debilitating, and no one likes to be told, oh, it's not real. And unfortunately, it is an issue that has come across patients I've cared for. So no one wants to hear that, and we don't want to hear it, and I don't want to hear that. So like I mentioned, I'm in the Air Force, so this is my example of what happens when everything looks good, don't know what to tell you. As a aerospace medicine person, seeing a plane like this makes me anxious, so I'll go past this. But the point is, this is where things tend to fall apart, and no one likes to be told, I don't know what to tell you. And I think that's something that, as clinicians, we need to be increasingly, again, more aware of as we approach patients and families with very difficult circumstances. So again, I like to focus maybe less on, all the mechanisms and pathophysiology of PoTS, and more about how do we think outside the box to understand all the different factors that go into not just causing symptoms, but the consequence of those symptoms. And I think really the best way to approach this is truly what it is, taking a really comprehensive and again holistic approach. The term biopsychosocial sometimes gets thrown around, but I think it's extraordinarily relevant in this case because there are clear biologic components. And if you look at the bottom of I'm not sure if my arrow shows on the screen, there are clear physiologic abnormalities from pain modulation to true autonomic dysregulation or dysfunction, to movement problems of the gut or motility issues, to the microbiome, bacterial overgrowth issues. So there are medical issues at play that clearly have an impact in terms of the emotional consequence anxiety, and depression that often ensues from long-standing symptoms. And I think it's safe to say, myself and anyone included, the more anxious you are, the worse you feel. It's awfully hard to have that optimal cognition. And the whole notion of brain fog being associated with this is not entirely clear. But when you put these symptoms all together in this model, it makes sense that is, whether or not it's cause or consequence, a factor that needs to be taken seriously. And then last but not least, when you throw in the environmental circumstances, like the patient I mentioned, you never tell a high achieving person, oh, well, you don't feel well, I don't know what to tell you. That is potentially the worst thing to do for someone's morale, especially under difficult circumstances. So all these factors have a role in terms of increasing stress, increasing sort of the downstream medical consequences. People who are anxious have worse GI symptoms. People who have GI symptoms have more stress. And when the environment, when there's a test or a highly stressful circumstances, it affects it. So it really is more of a dynamic circle than A leading to B. And my last point about this is that what it really underscores is that, we talk about team science in medicine these days. This is a team sport as well. And really isolating it in silos just doesn't work with all these working factors. And so we work as a multidisciplinary team. To me, I'm only as good as every member of my team. And I think that's really critical to understanding not just the gastrointestinal GI pathology or circumstances, but circumstances outside the GI tract that I may not have as much experience in. So I guess the analogy is the blind man and the elephant. We have all these symptoms, but again, the elephant in the room is still the elephant in the room. And the symptoms that are associated with POTS in general, to call them heterogeneous, we're putting it mildly. And so how do you connect those dots and validate the fact that other symptoms, even if they're not within your specialty, are relevant? And really what I think what it comes down to is it's hard to get the right answers unless you ask the right questions. And I think there's a tendency now that we've become so subspecialized that thinking outside of our comfort zone is anxiety provoking in itself. And what I encourage my colleagues and partners and collaborators is that, yes, I am not a cardiologist, but I'm allowed to ask about dizziness when you're standing or shortness of breath, and I'm allowed to partner with them to that effect. I don't have to have all those answers, but I think it's important to link that towards the bigger picture. So really, what's the goal is defining the phenotype. What is this individual, and what is this individual in terms of cardiovascular symptoms and headache symptoms and neurologic symptoms and GI symptoms? Because it's really hard to, number one, define what may be the driving force behind this, and two, what the natural history is, what the natural history of things are, until you really thoroughly understand the picture. And again, in a comprehensive way. So the question, how do you get the whole story? And this is a challenge. I would like to say we have 4 hours for every single patient. It's just not the way of the world. So one of the things we did, because our patients do take more time in terms of potentially long-standing history and other very important symptoms, we actually sort of have the pregame, the pre-clinic workout. And so one of the things that we've incorporated into seeing patients in our clinic is doing our homework ahead of time. Now, this is a little bit of a cumbersome slide, and I'm not meant to, I didn't mean to overwhelm folks, but we actually have an intake device or an intake questionnaire that we use for patients. And it really includes certainly detail of GI symptoms. It includes detail of tests and procedures that have been performed. It also takes into account other aspects of general health. And this is a very kind of truncated sort of a snapshot, but addressing issues like cardiovascular, shortness of breath, chest pain, urinary issues, skin issues. We do that, again, not to overwhelm the system, but to really have a good picture of whom we are meeting ahead of time. And again, I think the analogy is you got to do your homework. And for a patient who has seen multiple consultants and has had long-standing symptoms, to walk into a room and say, oh, what are you here for today? generally doesn't go very well. And I think, when you have the privilege of taking care of patients with complex needs, you need to, just like when we're young, we need to always do our homework. And as a team, this really helps us to really to mold and to shape the clinic visit. We actually, all the information we get back from patients, we actually discuss as a team weeks before we actually see patients, or a week or so before we see patients, again, to best prepare everyone involved and all the stakeholders in the patient's care. We also actually use specific instruments relative to symptoms. For instance, autonomic scores. We see quite a few patients with very debilitating nausea. We are certainly accountable to quality of life. One of my colleagues at Northwestern has come up with the patient-reported outcomes measurement information system. It's called PROMIS. And this is their website. This is a study that's been funded through our National Institute of Health, and it's been a wonderful and kind of up-and-coming measure of not just initial symptoms, but following symptoms over a period of time from the patient's perspective. And so again, it seems somewhat overwhelming. We don't send patients 200 pages of questionnaires. We try to, in as focused a way as possible, by looking at our intake, determine which are the appropriate measures to help us get an understanding of where we focus our attention. But my point is that it's not all simply, more ways of looking at GI symptoms. We have to look outside into other systems that can be very relevant. And so just to give some examples of things we do look at in using the PROMIS instrument. So in pediatrics, we have an instrument that looks at functional mobility, anxiety in the past several days prior to the appointment, fatigue levels, which are very relevant to overall health. And we also have an instrument called the Pediatric Global Health Scale that gives us a sense of, again, where patients are in terms of life and quality of life. And again, it's something that holds us accountable because we look at this on a visit-to-visit basis. And again, that gives us a way of gauging what are we missing, what's not coming together. So the tool helps us to describe patients, but it also helps us to be accountable for where our patients' needs are, even outside the GI tract. So now to get into sort of the nitty-gritty, when you send a teenage patient a stack of paper and pen questionnaires, especially in the age of smartphones, technology, and apps, this is the response you get. And again, it was an interesting way for a teenager to tell me to get my act together. But one of the responses from one of my young patients was, well, again, quite honestly, this sucks. Make an app for it. I mean, gee, if you're sophisticated enough to take care of patients, why can't you do that? And after my ego recovered from being talked down to by my pediatric patient, it really resonated in the sense that I think we need to be aware of not just the questions we're asking, but how we ask them and what's effective and what's not. And I thought about it when I go to my own doctor, filling out a questionnaire, how tedious and it can be just going from page to page. So, and I'll get to that in a moment in terms of why I think this is important towards understanding our patient population and symptoms. So in thinking about this, I went through some of the literature and talked to some colleagues, and the truth is, even as far back as 6-7 years ago, we do have apps for clinical conditions. This is actually an app that my colleague at Sinai in California came up with to address GI symptoms. And it was as simple as, where are your symptoms, how often are they, what makes it worse? What was interesting, it was a phenomenal development, but it was interesting when I went through this whole app, it was all GI. And while there was a review, it was really GI versus looking again at other circumstances that can be relevant to the symptoms. But when we think about it, there are other organizations and tools that we use to address more functional GI symptoms that are harder to define in terms of their mechanism and reason underlying them. And the Rome 4 Foundation actually is a group that looks at categorizing different groups of GI symptoms. And even the functional Rome people have come up with their own apps. So again, referencing the 15-year-old, it was probably time for us to get our act together. So about 5 years ago, we decided as a team or as a research team, to these start to explore the idea of how can we more optimally collect data from patients in a way that's not, I guess, repulsive to them, or at least more more of a positive experience. And the biggest feedback that we got was, going page to page. Well, if you answer yes or no, if you answer no to a question and you can go on to the next one, it's again more visually pleasing to the user and potentially more effective and more likely that you're going to get all the information you need. So we also want to incorporate the comorbidities, the coexisting symptoms, and eventually can use our hopefully our creative skills to extend this into other types of software and artificial intelligence towards monitoring symptoms, towards really gauging how to focus treatment. And so we got a little more sophisticated a year or two later, and had a little bit of a more pleasing platform. And our future is really, our future goals are really to be able to have more of an interactive encounter with patients even during the visit itself. We don't have this glass table invented yet. We're still working on how to design this. But one of the things that caught our attention in our feedback from patients was that in the day and age of documentation, there are clinicians, doctors are constantly typing and not making that eye contact with families. And so we thought, well, if we want to get the information, can we work together again as a partnership? Because one of the things that I think the most important thing our data showed is that patients and our parents of patients very much want to share the details of how they're doing with their provider, with their doctor. But there really isn't an easy way to do it, short of those very cumbersome questionnaires. And what's even more interesting is the clinicians and the doctors who are always trying to keep up with things, their documentation, they want to incorporate the patient's perspective as well. But the challenge is, how do you do that in a way that is not so cumbersome that you fall partnership between patient and between clinician. There we go. So really, we're at the point of further exploration, and just to underscore, the patient's input, whether it's patient, parent, or both, is just vital to us understanding the big picture. And incorporating these outcomes is truly one of our important goals, or critical goals as we grow and as we understand our program. We really want to implement the notion of shared care. This is again a partnership, not just one person dictating to another, and coordinating expectations in terms of both the clinician, the provider, and patients. I think it helps to define that from the beginning, and helps to define it in the subsequent visits, because all of us want to say we have a one pill that's going to make all your symptoms better. And I think presenting an unrealistic expectation lets everyone down. So in some ways, that's understanding and establishing that relationship is really one of our key goals. And we'd like to be able to have a tool that doesn't replace the face-to-face time with patients and clinicians, but really augments it. And importantly, taking that data, or taking the data in a consistent way and being able to study it. We, in the past 4 years, have been fortunate that we've been able to develop a fairly large clinical registry of our patients. Again, it's a safe institution approved database where we look for trends to see how we can do things better to advance the science. And so having something that consistently collects the data actually is again, from a research standpoint, ultimately, I hope helps us to understand the condition and the treatment. And so one thing I just wanted to share with you, not to go too far off topic, is getting back to how do we collect this. When we came up with some of our initial prototypes and iterations, we thought we had the best thing. We're going to revolutionize the world and collect data better. But one of the things we also didn't take into account is that, whereas we may think it's the next best thing, we need to know our users. We need to know the people who are actually face-to-face with this. And so keeping sort of with the Apple approach to life and what's called user-centered design, we've really kind of changed our approach towards the app, so to speak, that the 15-year-old referenced, and keeping in mind, who both the patient and the provider that's involved in this. And again, our goal really is to develop an interactive or innovative platform but listening to the folks that actually are going to be using this. And so the goals are to improve input to care from patients, but also to enable our clinicians to not just improve communication, but their care and management of patients, particularly with complex conditions. It is really becoming increasingly more difficult to thoroughly get all the information you need in oftentimes a very short clinic appointment. So again, our goal is to augment the visit, not to necessarily replace the face-to-face time with a tool. And again, so getting back to why does it matter? Well, when we think of GI disorders and autonomic dysfunction, there's quite an overlap. And if we don't see those connections, if we're unable to identify the dots and then connect the dots, we prolong the time to really come up with an effective management tool. So for instance, when we think about nausea and vomiting, there are motility related issues, again, movement of the gut issues, gastroparesis, abdominal pain, distension, constipation is an issue, which sometimes opens up the question of the Pandora's box about connective tissue issues, Ehlers-Danlos syndrome, joint hypermobility, and even swallowing issues and motility issues in the esophagus. So my point is taking this home into why it's relevant. My colleagues from Johns Hopkins, when we were all in the same place at the time, actually looked at this several years ago. This is 2005. And my point of showing this is not to get into the nitty-gritty, but Peter Rowe, who actually focused quite a bit of his work on chronic fatigue syndrome, and Sean Sullivan, who worked with me in motility, one of the things that they looked at in patients with stomach or GI symptoms and orthostatic dizziness or orthostatic intolerance was most patients actually had at least 2 or 3 manifestations of GI symptoms in association with conditions like PoTS. But what was more telling from this is that most patients had these symptoms for at least a year before the dots started getting connected. And I bring this up is that there's a remarkable delay in diagnosis, not necessarily because we're missing the little picture, but we're missing the big picture, connecting the notion that dizziness and nausea may have a temporal relationship. And so what was interesting in Sean's study and Dr. Rowe's study was that simply by treating the orthostatic intolerance, there was actually a fairly large, in this case, resolution or improvement in the GI symptoms. So knowing what's driving the bus in certain ways actually helps dictate the best treatment. And so for patients with, in this study, endoscopy after endoscopy wasn't the answer. Addressing the orthostatic PoTS autonomic issue was really what had the downstream effect towards overall improvement in stomachs or GI symptoms. And again, this is a very busy slide, and the intention is not to go through all the nitty-gritty details, but this is nothing new in that this relationship between GI symptoms and the autonomic nervous system has been around for a while, both in adults and pediatrics. Again, this is just one example of a study that looked at patients with PoTS and rhythm issues, gastric rhythm issues. People who have PoTS, I mean, it's hard not to say you haven't had a 12-lead ECG electrocardiogram. Well, the electrogastrogram is like the ECG or EKG of the stomach. And so, again, trying to link the electrical part relative to the PoTS, looking at patients who have, again, abnormal rhythms in their stomach and dyspepsia or discomfort in the upper part of the GI tract. And even in terms of motility changes, why patients feel full early, why they become malnourished, why they can't eat. So again, this link is, and I could present probably about 100 more studies, which I won't do, but the point is this is nothing new. And so by a similar token, if it's nothing new, it's something that should continue to be explored even on a day-to-day basis as we see new patients. So this is my keeping track of the time, but this is my quick break to tell a story of how I got into all this. So when I was a young faculty member, I would see patients with all sorts of GI symptoms, from pain, constipation, vomiting, nausea. And on one circumstance, I was seeing actually a basketball player, and just to put it in perspective, he was about over 6 feet 5 inches, close to 2 meters, to put it in some perspective. He was a very big individual, And I was seeing him for his belly pain, and in fact, he had fairly challenging issues with constipation. And toward the end of the visit, as I did when I was a bit younger, I said, "Well, anything else I need to know?" And his response was, "Well, I faint a lot, but that's not you, that's someone else." And I asked, "Well, so you faint a lot. So what does that? Tell me more about that." And he said, "Well, when I stand up and I'm for long periods of time, I see flashing lights, and sometimes I pass out." And of course, being young at the time, I said, "Well, show me how that happens." And so I had him stand up, and clearly, in hindsight, that may not have been the best idea, because I certainly had to put my back into catching a 6-foot-tall basketball player. But he proved his point, and the other question that came from it was, "Well, what else is happening when you're standing up about to fall on me?" And he would become clammy. He'd become more nauseated. His symptoms just exacerbated. And so, making this link between, well, gee, is there a relationship? We started looking at patients with what proved to be POTS before and after treating the POTS. And it was interesting, similar to Dr. Sullivan's study, we actually saw pretty remarkable improvement in nausea scores, in dizziness, in belly pain. And what was interesting, we kind of threw this in early on, was our patients actually started functioning better. They started actually being able to go back to school, because the issue that comes up with patients is, well, these are young kids, they don't want to go to school. The truth is, our patients are quite the opposite. And when they actually felt better, their functionality and ability to perform in school, socially, and at home improved. So this is sort of how I got, I guess, into this line of work. And it took a patient to sort of quite literally hit me over the head to make it clear to me. Later on, we started to get a little more sophisticated, and we started thinking, well, some of those questionnaires that we're using, are they predictive of how patients will do? And this is actually just, again, a lot of information, not to belabor it. For our nausea profile, a nausea questionnaire that we used, one of the things we found is if we use this questionnaire, particularly one section of it that looked at not specifically GI symptoms, things like fatigue and dizziness, we actually found that certain parts of the questionnaire would actually help us predict the response on tilt tests. And this, excuse me. So this positive are our patients who tested positive during a tilt test, and these are patients that tested negative. And so really it was a nausea scale, particularly the parts that looked at non-GI symptoms, that really helped us put to context what was happening in these patients. And so again, this notion of comorbidities or coexisting symptoms, it's taking all these dots and these circles in the Venn diagram and putting them together. My colleagues up in Wisconsin, north of Chicago, actually demonstrated this in the POTS patient population. You know, patients with fatigue, sleeping issues, dizziness. And I think the challenge, of course, is, wouldn't it be nice if we could say, oh, this is the root cause of all problems? And so I use this expression quite a bit with my colleagues and the patients, that correlation, unfortunately, doesn't always prove causation, which means, again, we have to take a very individual symptom approach to caring for patients. But taking it from a different perspective, my colleagues up north looked at how the comorbidities in POTS. We want to look at it from the perspective of nausea and coming to see the gastroenterologist. And so we looked at this this was actually earlier this year, in patients with nausea, which we find to be one of the most debilitating symptoms of all the GS that patients have. And what's interesting is when we looked at this patient, it didn't show a whole lot: endoscopies, x-rays, colonoscopies, CAT scans. And so again, are we missing the boat in these patients by just not knowing the history? But when we looked at the comorbidities in these patients, the things that were most prevalent: pain, headaches. The third thing on the list was dizziness, was orthostatic intolerance. So the number 3 issue on the list for patients with nausea was something that most people weren't even asking about. And I do apologize, I'm going a little bit faster just because I want to, again, be aware of time for questions. But one of the things I mentioned before is the cause and consequence. And when you have patients who have been debilitated for long periods of time, it's not a surprise that anxiety and sometimes even long-standing depression can be a long-term consequence. And we wanted to be aware of that. And actually, we looked at a group of our patients where we used that nausea profile instrument to look at kind of acute anxiety symptoms and long-standing anxiety symptoms. And not a surprise, the type of quote-unquote anxiety that was most predicted was long-standing, enduring anxiety symptoms. So again, it has an impact in terms of life, in terms of the way we think, in terms of our awareness. And I guess the analogy I would give in terms of it being a consequence is, if you walk into my office and every time you walk into my office, I threw a bunch of tennis balls at you. Well, the second time you walk into the door, you're going to have a heightened sense of awareness and probably duck. And so there is this notion of the brain and the gut and the gut and the brain and how they interact and how they influence each other that needs to be taken seriously as well. And so again, how do we use the data to guide treatment, to guide focused treatment? So on the positive end of things, all of us finally decided it was time for us to sit in the same room. And this is actually a review that the Pediatric Working Group of the American Autonomic Society put together, myself included. And the reason for this group was we kept talking about, well, one person does it this way, one person does it another way. And Dr. Chalimsky, one of my friends and colleagues up north, and I sat and said, well, it's time for us to sort of put our heads together and again, hold each other accountable for all the aspects of this. And so we put together this review, realizing, of course, that most of what we wrote was what we didn't know. But what we do know is again, this integrated team approach is vital to really effective patient care. And so we do address symptoms by systems. And so the thing that always caught my attention in working in the institution I'm in now is a fair number of our patients with predominant dizziness, cardiovascular symptoms go to the cardiologist and they get routed my way subsequently, or chronic nausea, I route them to the cardiologist. And so, yes, it's not a big surprise that patients with POTS, likely because of pooling of blood, other things that we sort of postulated as mechanisms, go to the cardiologist. And it's not a surprise that patients undergo a litany of medications, compression devices. I'm sure this looks familiar to probably, if not everyone in the audience. How many times have you been told increase fluid and salt intake, recumbent exercise, of which there is very good data, and even things like biofeedback. And the part that's a little bit more controversial is the notion of, do we do IV fluids? And this was something we addressed as a group where we did have concerns, obviously, about long-standing intravenous fluids for patients. But again, our conclusion was more information is needed. But again, there's a whole litany of things to increase intravascular volume in patients with predominantly cardiovascular symptoms, the orthostatic dizziness. But you may go to the neurologist as well when migraine headaches are the predominant symptom, or pain in the legs, or complex regional pain syndrome. So my point in going through all this is that there's a lot many roads to Rome, so to speak. And so the notion of small fiber neuropathy, again, underscores why we need partnership in our other specialties. Now, of course, I was brief. It wouldn't be a gastroenterologist giving a talk if we didn't talk about something GI related. And I feel like I'm getting into the lower part of things, so to speak. Well, constipation, poop is a big part of our practice. But it's not meant to, again, number one, discuss to you before dinner, but also to reiterate that symptoms of pain and constipation are very relevant, and it sometimes gets a bad rap because it doesn't sound as perhaps important to the outside world. But I show you this picture, not to, again, to make everyone disgusted, but this is a patient I took care of who subsequently wound up having part of her colon removed. And the thought behind this was, in addition to POTS symptoms, in addition to constipation and pain, well, there were connective tissue issues. There was joint hypermobility that made this patient more susceptible, which all of a sudden puts the constipation into a bit of a new context in terms of not just its severity, but its significance. And so in this patient's case, this is where, again, secondary consequence. Well, it was the constipation what was causing all this patient's symptoms. No, but the downstream effect of the colon becoming damaged from connective tissue problems and constipation that hadn't been managed, well, the colon was large. And when we did what's called manometry testing, we really found, effectively speaking, the colon was not moving very well. And so really, one of the, I guess, the points for this is that whereas, POTS is about dizziness, about nausea, about passing out, it's also about really being effective in terms of other systems, like having an effective bowel management plan early on. It's another tool in the large toolbox of treatment. And again, I'm just going to continue moving along just in the interest of time. But one of the things we've looked at now is it's not just the stomach. Are there connective tissue issues in the stomach? And this is some new technology we're using right now to get a sense of how stretchable, unstretchable parts of the stomach are. And I'm just going to go past that for a moment. But really, in terms of other treatments that are a little more avant-garde and new, the notion of giving things like Botox to relax different muscles. I have another story about a patient who had really significant joint issues where she was overcompensating with contracting muscles. Again, the point is, there's so many variables that have to be considered towards gauging a really effective treatment strategy. And so I'll just kind of touch on this, that yes, hypermobility is something that needs to be a part of our intake. Patients with Ehlers-Danlos syndrome have nausea, pain, constipation. And so we do make doing our bite and score and our assessment a routine part of our intake with patients from the start. So from what's my kind of dream standpoint? Well, instead of having a GI clinic, the notion of having a neuro GI clinic and a neuro GI and autonomic clinic where we really combine the resources and the team to look at some of these very multidisciplinary aspects is what we're trying to evolve toward for specialty care. Because all of our patients, well, let me be correct, our patients oftentimes have more than one problem, and it's not that one problem is more significant than the next, but the interrelationship is so crucial to recognize. So again, just to give you a sense of, this is our tilt lab. When I first started doing this, there was a tilt table on a monitor, and you can tell we now look at blood perfusion to the brain, what's called cerebral mirrors. We actually incorporate doing the EKG of the stomach, the electrogastrogram. And really, to me, a tilt test, no one necessarily likes a tilt table test, but the tilt test is important just as important as it identifies blood pressure and heart rate issues, as it is manifestation of symptoms, as it is manifestation of electrical issues in the stomach or changes of blood flow to the brain. And so really, in a lot of ways, part of our objective in doing a tilt test is not necessarily to make people sick, but to at least reproduce symptoms towards understanding them better, whether it's through electricity in the stomach or blood flow to the brain. And since we mentioned the brain, and I am a neurogastroenterologist, I'll shoot past this reasonably quickly, but I mentioned before that the longer people are sick, the more your brain adapts to the circumstances. The tennis ball is being thrown at you. And we actually looked at this in our patients with autonomic issues and found that there are certain parts of the brain that over time actually, when I say lit up more, were more active. In other words, patients have developed more what's called self-referential thought. The more aware they are of things. And it's awfully hard to escape your symptoms when your symptoms are a 24-hour part of your life. But again, like I said before, when you put patients through a test, what is your question? What are you going to do with the information? And we found that in a lot of our patients, the notion of actually doing biofeedback in certain circumstances actually helped in terms of, if you will, auto-calibrating the brain. And this is just an example of what was called EEG biofeedback, where we looked at a patient before biofeedback in terms of this distribution. And again, I'm not going into too much detail of the left brain, the right brain, as far as the parts of the autonomic nervous system. And again, if you'll trust me, the sort of translation from this picture to this picture also translated into improved symptoms. Was it a cure? Absolutely not. But again, it helped in terms of some of those self-referential issues that we identified on the MRI testing. So again, as we get toward the end, how do we treat patients? Well, it's a symptom-based approach. It's this model of looking at all aspects of patient care, the physiology, the environment, the cognitive aspects, and the emotional parts. Really, I think just putting sort of the proof of concept, part of my negotiation and coming to the institution I'm in came with having a medical psychologist integrated within our clinic. Again, not to replace a medical diagnosis with a psychological diagnosis, but to really work in more of an integrated way towards patient quality of life and function. So again, I keep saying, and I'll say it again, it's a multidisciplinary team that is just vital to understanding and caring for our patients. So again, one of my sort of pearls when I've presented this in the past is, breaking down the silos. This needs to be a team collaborative effort among the disciplines, including the primary care clinician. And I stole this slide very nicely from one of my colleagues. I think she's forgiven me, but she had a big thing for elephants, and so I just enjoyed it. But really, the idea of working together. It's for one provider to solve all the problems is just not doable. So this really is something where it has to be a team effort, so everyone can work again in an integrated fashion. And again, I let my now 11-year-old let me borrow this picture of him. When we try to do this solo, we tend to bite off more than we can chew, and he thought that was cute, so I thought I would share it. But really, this is something where I think we're most effective when we're accountable to each other, when we're accountable to our patients and our team. I think we tend to work a lot better in those circumstances. So just to conclude, because I know I'm getting a little tight on time, I think it's safe to say that the cause of the GI symptoms we see with autonomic disorders such as PoTS or again, orthostatic intolerance, it's multifactorial. It's a spectrum presentation, and I think our job as not necessarily detectives, but as integrators, is to pull these symptoms together to identify the dots, to connect the dots. The symptoms themselves may be a consequence. Just in that example of the patient who had surgery for refractory constipation, the constipation wasn't the root cause of the problems. It was sort of a consequence of longstanding symptoms related to autonomic problems, and now a colon that didn't work. So again, correlation doesn't always equal causation, but it means we still need to look at these symptoms as they affect function. And again, that just sort of underscores the issue of being very aware of connective tissue problems and working together with our rheumatologists and geneticists to that effect. I think if I can give some words of wisdom, I think it's very important to choose tests and treatments wisely. I've never had a patient that said, oh, another colonoscopy would be a wonderful way to spend my day. No one really gets excited about these types of tests. And so I still subscribe to the notion that if we're going to put someone through something like this, there has to be a question that we hope to answer, positive or negative, towards guiding treatment. But we need to be aware that all the symptoms do have some relationship, and really flushing that out beforehand, I think, is kind of part of our job, part of our charge. Again, if you wanted to find this very diverse patient phenotype of PoTS, of orthostatic hypotension, of autonomic issues, if you want to get the right answers, you got to ask the right questions. You got to ask them in a way that's conducive towards getting an answer, towards not overwhelming your patients or your providers. I mentioned before, it's team science. And I think also the transparency. I wish, I could tell you we know all the answers, we don't. And I think sort of being open about that, about sort of being involved in developing a relationship with your patients, that this is a process towards guiding realistic expectations, really kind of underlies what we should be doing as healthcare providers. And this is my happy Air Force plane picture compared to the one on its side. So I want to end on a happier note. And I think that's all I have. And again, I apologize for running a little bit over the time, but I will turn it back and maybe answer some questions.
Well, thank you very much. That's absolutely fascinating. And I can see what you mean about how it's a topic where, you could talk for absolutely hours. There's so much to cover, isn't there? So thank you very much for providing that fantastic overview in a 45 minutes. So thank you. Right, are you happy to crack on with questions?
Let's
Okay, we've had some great ones come through. I don't think we'll get through them all, but as you've kindly offered to have a look at them afterwards, I will send them over to you, and then we could communicate them with everybody. So first one is, when patients with PoTS have GI issues, are they more likely to be caused by PoTS itself or by the mast cell activation syndrome?
It's an interesting question. Didn't really touch upon the mast cell issue as much. And it is something that we do address. I think it gets back to that correlation causation part of things. It's hard to draw that line from point A to point B. I do think the PoTS issues actually probably have a fairly substantial kind of root cause to the GI symptoms, more in terms of blood vessel issues and blood flow. Now, how does the mast cell issue go along with that? Is that the right inflammatory trigger towards the neuro hot symptoms, which leads to the GI symptoms? Is it that sequence of events, or are they functioning independent? So the easy answer is I don't think any of us really entirely know, but I think the point of the question, which I think is really valuable, is right. You have to be aware of the mast cell issues, and we do actually, just to reference that, we don't necessarily do endoscopy on all of our patients, but when we do, one of the things we actually will oftentimes do if there's a question of mast cell issues, including hives, again, even anaphylactic reaction, we do actually biopsy endoscopically to stain for mast cells, number one. And number two, we partner with our allergy immunology colleagues, and I can certainly reference Ann Maitland, who's a wonderful friend and colleague of mine in New York, who I work with closely. So I think the answer to the question, truthfully, is we don't entirely know, but we see that the relationship of all those symptoms, and we try to connect the dots, but it's hard to actually definitively prove beyond a reasonable doubt, so to speak.
Okay, brilliant, thank you. We've had a couple of questions about excessive and chronic burping, and do you have patients who experience this, and what would you advise generally?
Yes, that one I think I can, my hypothesis, you may or may not agree, but one of the questions I would ask to that question is, is it belching kind of in relation to other GI symptoms like nausea? And the analogy I give is nausea. My mentor actually for 45 years has focused his career on studying nausea, which is amazing to me. They spent almost half a century. But nausea is a horribly pervasive, miserable symptom. And the analogy I think of is when people are nauseated, they swallow. And they swallow, and again, sort of showing the motion. The reason I bring that up is the more you swallow, the more you effectively belch, because you're bringing more air into the GI tract. And so that's one point about belching, is that yes, we frequently do see it, and it's really more because people are just trying to cope with the just debilitating nausea. The second point is what it can also bring up, again, I'm not saying with every single patient, but I was referencing some motility issues that can sometimes go along with POTS and autonomic conditions. And so we also have a patient population that we've been studying recently where the actual muscle movement in the stomach and what's called the pylorus are not working effectively. So is it one versus the other? Is it both? Or is it sort of a combination depending on circumstances? Probably both. But again, I think what it really underscores is not an interrogation of your patient, but really knowing the sequence of things. But the short answer to your question is, do we see belching quite a bit? Yes. Do we see it in association with chronic nausea? Yes. Do we sometimes see it in association with gastroparesis or motility problems in the stomach? The answer is yes as well.
Okay, brilliant, thank you. Can splanchnic pooling cause excessive chronic bloating and abdominal distension in patients with POTS, and how can this be managed?
Yeah, the splanchnic pooling is an interesting point, because again, it gets into what are the mechanisms underlying this. What's easy to establish is, yes, we do see an association with splanchnic pooling and stomach or abdominal upset and distension. But is it because simply, well, because there's blood pooling versus blood flow to the gut? What I may present to you is that when you're pooling blood in the veins of your mesentery, your splanchnic vessels, you're also not perfusing it as well to organs like the kidneys and the gut. And again, this is a little bit of a loose relationship, but my point is, if the blood is pooling somewhere, it's not going elsewhere. And so why do people faint when there's splanchnic pooling as well? Because there isn't sufficient blood to the brain. So one of our arguments has been, if there's not sufficient blood flow to the GI tract, can that contribute to the discomfort? Can it contribute to the neurofunction of the gut, the stomach, and the colon? I think the answer is probably yes, and there's been some evidence to support that sort of use the word perturbation or different abnormal flow to the gut. Kevin Kelly looked at this years and years ago, but there hasn't been a lot of work since that time. But I would say, so the answer is yes. There's probably some potential causal relationship between blood flow secondary to pooling of blood in the mesenteric vessels and splanchnic vessels. The other thing to consider too, just again, making this a multivariable equation, is, well, what does it make any difference in patients who have connective tissue issues, Ehlers-Danlos syndrome? And the challenge there is, can Ehlers-Danlos syndrome affect your colon, more stretchable, more distended, more apt to bloating? The answer is yes. can Ehlers-Danlos syndrome and connective tissue issues potentially have an impact in terms of the blood vessels, making them more stretchable, more of a capacitor? The answer is potentially yes. And so there it goes again into the, what's the primary culprit? If you're more stretchable, pardon the expression, but in terms of your connective tissue, odds are you probably have more of a capacity to hold on to blood and pull blood more. But taking that from that to where that leads to blood flow to the intestine, to the colon being stretched out, to being more bloated, there's so many, I guess, bumps in the road, or so many potential avenues that you can go off on a tangent. It's hard to definitively prove, but the answer is yes. It probably is related to blood flow, or maybe some difference in blood flows in the gut that sort of goes down that domino effect afterwards.
Okay, thank you very much. I know we're at time now. Are you happy to carry on for about 5 more minutes, or?
Absolutely. I went over, so we'll keep up.
I know you've got a busy day of teaching ahead, so I thought I'd check, but thank you. We'll just do a couple more then, and then, because they're flooding in thick and fast now, but we'll cover a few more in the next 5 minutes. Is epigastric pain, where the epigastrum is tender when palpated, common in PoTS? I find this fluctuates and gets worse with my symptoms flares. I feel PPEs may provide symptom relief, but don't address the underlying problem if there is one.
Well, I would agree. I think, acid suppression is, I think it's kind of I would say a weak treatment, but because it really does just that, it suppresses the acid. But what I think it also underscores too is what are the other circumstances. So yes, do we see patients with epigastric pain? Absolutely. Is it because of the stomach, the pylorus, the colon, all the above? Potentially, but I will say we actually do have a study that we just actually submitted, and we'll be looking at prospectively at the pylorus. And so the epigastrium, that part of your belly, is where your stomach effectively empties. And if you look actually in some of the adult literature, and hopefully in our literature soon, that may indicate that muscle, that I call it the brain pattern, but the actual exit of the stomach, the pylorus itself, may not be functioning adequately. So potentially, again, I can't tell you exactly, how blood flow changes and why there's worsening symptoms in certain parts of times of the day, but is it possible or potentially probable that the pylorus is either in spasm or causing more symptoms, causing you to feel more full during this time? I would say from what we've seen in several of our patients in a separate cohort, not every single patient has that symptom. Actually, it seems to be more than just a coincidence. I would agree with you from the standpoint of the medication and the acid suppression that if this was inflammation alone, this would be an easier problem to solve. I agree that I think it's probably more muscular in nature. It's probably related to parts of the stomach that are maybe that they're contracting well, but not relaxing as well. And that's something that we've seen from our initial studies and looking at things. So yes, it is something we see. Yes, it's something that sometimes will change our focus from just addressing the dizziness to more motility issues. But the question asked is really to that effect, and where do we focus our attention? Some patients have caused me to focus on the colon, sometimes me to focus on the stomach. If someone comes to me with epigastric pain and feeling full early, what's called early satiety, we're going to probably have a different avenue we're going to pursue before going down different paths.
Okay, fab, thank you. What would your suggestion for the reflux and nausea be?
That's about a 2-hour answer, but I'm going to try to see if I can I think the sort of more global answer is my first answer would be the patient interrogation in the nice way, meaning getting information, because to that effect, if someone comes to me with nausea, I usually ask them, well, is the nausea worse when you're dizzy? Is the nausea worse when you're eating? Is the nausea worse in the morning? Is the nausea associated with a headache? And I'm not trying to just be facetious about it, but in all honesty, it's so important to know those relationships, because like the patient who fell over on me, basically he said, yeah, I get nausea when I'm dizzy, when I'm standing up right before I pass out. That particular correlation is really vital to understanding the avenue you go. So some easy things in general, when we do see the association between dizziness and nausea, yes, we push this is Mayo Clinic and us, and we push the fluids, we push the salt. We have a low threshold to potentially do tilt table testing to reproduce the symptoms and potentially add a medication if the hypothesis is that the dizziness is driving symptoms. I'm asking you to repeat the other part of the question because we were asking how do you treat the nausea, but there's more to it, I think. Just want to make sure I addressed it.
Yeah, what would your suggestion for the reflux and nausea be?
Oh, the reflux. Okay, and that's an important part and something we do ask about as well. And it takes me back a little bit to the other question is, well, what's underlying the reflux? Most people get reflux at some point in their lives, and children when they're little and then they tend to outgrow it. But if reflux is the predominant symptom, or reflux and nausea are the predominant symptoms, it doesn't make sense that that would just develop out of nowhere. So again, there are some ways of empirically addressing it, like you mentioned, acid suppression. But the other question gets back to that epigastric pain. Is this an issue where because there's a neurologic issue with POTS and because there's a motility issue in the stomach, we need to focus on aspects of the stomach that may not be functioning well. And so it's a little, I'm trying not to be a politician and give a wishy-washy answer, but I guess my point is I think the approach is going to be, okay, well, tell me more, and then tell me more, because then I think if the issue really is the stomach is not emptying out of it, causing worse nausea, causing worse reflux symptoms, well then I showed the picture of us doing Botox in the pylorus. That may be the right solution. But if it's more, we're not optimally managing the dizziness, that might be the right solution. So I think it's really a matter of sort of dissecting it. And needless to say, we do our clinic visits with patients take a while. They take an hour, and I'm sure patients after an hour, as I said, are probably well done with me. But I think it really is so essential because all these questions you're asking are so relevant, and I think it just takes an hour to really pull it together, even in addition to having the written description beforehand. So even we do, because of the COVID thing, we do a lot of telemedicine visits now. And I like to say, oh, they're much shorter. They're not. I think that the value of sitting and communicating with someone about the questions that you have and then dissecting it further is really what we can do. So so the only positive thing about COVID now is, yes, we get to see patients from all over the place because we can do it like we're doing our conference today. So again, I'm sorry, I hope I wasn't intentionally vague with the answer to the question, but I think there's so many variables in the equation. I think if I hear reflux and nausea, I'm wondering, does that go with bloating and distension? Should we be thinking about the stomach? Do you get full earlier? Do you get full quickly? Are you losing weight? Do you have other symptoms? These are the questions that start running through my mind towards saying, okay, well, yes, the reflux is because of your stomach not working well. Let's focus there. Or because your colon's not working well. Let's focus there. So like I said, I think the most valuable part of our clinic visits, yes, the physical exam is vital, but really getting a detailed history of this time sequence of things and what's the most, I ask patients when I see them, I don't say what's your worst symptom, but I do, I say, what's the most debilitating symptom? And that's not meant to say we don't care about anything else, but it really sometimes helps direct things toward what we prioritize. The second thing that sounds like a weird question to ask, I oftentimes ask, where's your nausea? Sometimes people look at me and I'm a little crazy when I ask that, but my mentor told me this. And I've had patients who oftentimes will point to the upper stomach, the epigastrium, like you mentioned. I've had patients who point to the low part of the belly. I've had some patients point to their head in the context of migraine headaches. And so, they're kind of weird questions, but it really helps us to hone in on where we should be focusing our attention. So your questions are excellent. They make me want to ask 100 more questions to you. So I'm sorry I'm answering your question with a question.
No, I think I'm sure that's very often the case, isn't it? It's needing to dig deeper. So I think we should probably leave it there, if that's okay. We've had loads of fantastic questions. I think quite a few comments as well, just about how refreshing it is to hear how you're working and working collaboratively and working as a team. I think some people I think have asked, how do you actually get that to happen?
You go home late at night.
Yeah.
But I will say that I work with some wonderful people, and I think we have a very positive dynamic, and I think that really helps a lot to make it I guess the word enjoyable is not the word I would use for something like this, but really a very positive experience, and hopefully that reflects in the way we present ourselves. So we enjoy what we do.
Well, it sounds fantastic and very refreshing to hear. So right, on behalf of POTS UK, I'd like to say a huge thank you. It's a lot of work that goes into these presentations, the preparation for it, us meeting ahead to make sure that everything's going to run smoothly. So we really are grateful. There's lots of comments coming in from everybody saying thank you very much and how helpful it was. Just a reminder to everybody listening, it will go on to the POTS UK YouTube channel. I'll get it up there as quickly as we can, and the link will go onto our Facebook page. If you have any questions, if you email the trustees at potsuk.org, and we will do our best to answer them. And I've also got the questions that have already been asked so far, so no need to send those ones in again. But yeah, thank you everybody very much for listening, and thank you Dr Fortunato for giving up your time. And yeah, I hope everybody has a lovely Christmas and New Year. Thanks ever so much. Thank you, bye bye.